Hello, everyone. We're happy to see all of you today. In this hot weather, this room doesn't feel too bad, does it? We're really happy to have with us Dr. Kyle Greenman from
and the role that we play in terms of supporting people's health when they have things like movement disorders, such as Parkinson's disease. So to do that, I'm going to cover some basic, very basic information on cognition in individuals with Parkinson's disease, some of the basics of what we do as neuropsychologists, what evaluations look like for individuals who come into our clinic and want to get an evaluation completed, what the results and recommendations might look like for somebody, and how we kind of integrate that and provide support for people. And then obviously any questions or concerns, anything that you would like to ask me about that I didn't touch on, I'm perfectly happy to talk about that following the presentation, and I'll even hang out afterwards if anybody has any one-on-one questions they might want to ask on social work group. All right, so before I get into the presentation itself, I just want to make sure that you know questions are welcome during and after. Just raise your hand so I at least know you're talking to me, and then I'll try and answer your questions. There are several frequently asked questions that I got sent in advance of the meeting, and I wanted to let you know that I've worked them in throughout the presentation. So hopefully that'll address some of the things that I hear in clinic, and also some of the things that some of the group members have expressed to others. And like I said before, I'll stay after the presentation for additional questions if needed. So, as everybody in this room probably knows, one of the first signs of Parkinson's disease for most people are physical changes, things like tremor, rigidity, difficulty with movement. But one of the hallmark characteristics of the condition, unfortunately, is changes in thinking skills as well. So in terms of being a neuropsychologist, I worry more primarily about cognition, or your thinking skills, and also your functional abilities. The kinds of things that we often see as changes in people's thinking or cognition with Parkinson's disease are reductions in language abilities. So sometimes finding the right word to say or even articulating that word can be very difficult. Memory can also change. So learning new information can be more difficult. It can be harder to recall that information. Attention and working memory can also change. So the ability to focus or to maintain enough kind of processing capacity to engage with tasks can be difficult. And also slowing down. So kind of slow cognition that kind of parallels some of the physical changes that some people with Parkinson's also experience. And then executive functioning. This is a big umbrella term, but it kind of includes things like planning, organizing, decision-making. These things can also change over time with behavioral Parkinson's. Now, when we think about changes in cognition, people often immediately jump to the term dementia. That's one of the first things that people often ask me. They say that they're worried they might have dementia. I want to kind of clarify something. Hopefully we can educate, 40 or 50 people today about this, and then I can continue my march to improve this knowledge along the way. But dementia is not automatically called, the result of changes in your thinking skills. Just because you have trouble with memory, trouble with language abilities, doesn't mean that you have dementia. Dementia is a very specific kind of definition that includes difficulties completing functional activities. So this is things like you can't manage your checkbook any longer. You're not able to do day-to-day functional things without assistance from other people. That's when we reach that kind of dementia diagnosis. Before that, it's something called mild cognitive impairment or mild neurocognitive disorder. This just means that relative to where you might have been at your baseline. So we kind of estimate where that might be. Relative to that point, if you're having some cognitive difficulties, you can still manage to do your day-to-day tasks and activities. We don't call that dementia. We call that mild cognitive impairment. Okay? If you're starting to have more difficulty, you can no longer balance your checkbook. You're having difficulty making phone calls, preparing food, things like that. Then we would look at potentially calling something like that dementia. Individuals with Parkinson's disease sometimes develop dementia over the course of their illness. Not everybody does, but this does happen in individuals. Most people will have some cognitive changes, so that could be that mild cognitive impairment that I was talking about, but it can progress to the point where you require significant assistance with the cognitive tasks of daily living, not just physical things. And when that happens, we might provide a diagnosis of Parkinson's disease dementia. Now, neuropsychological evaluation is important because it can help us differentiate between what might be causing some of these cognitive difficulties individuals can experience. So many people, when they start to have memory difficulties, if they don't have other conditions along with that, they might presume they have something like Alzheimer's disease, which is the most common cause of cognitive decline in older adults. That's not necessarily the case, but our job as neuropsychologists is to help understand whether or not you might have that condition in addition to potentially Parkinson's disease, or if there's another condition that could be causing cognitive change aside from things like Parkinson's disease. So, one of the questions that was on the list that I got emailed, which I think is a very interesting question, is how do I talk to my family and my doctors about changes that I might be noticing in terms of my memory? So I often have to kind of, prompt this information for people when they come for our evaluations. So I think it's good to talk about it. I would say you should be really direct in expressing your concerns, especially with your care providers. We spend a lot of time in school. We spend a lot of time studying and reading on your condition, but we are not mind readers. So if you don't share what you're experiencing, the difficulties you're having, it can be really hard for us to determine whether or not something like a neuropsychological evaluation is helpful, or whether or not you might need additional assistance. I'm really bad about this too. Just because I'm a doctor, it doesn't mean I follow my own advice. But I will go to my doctor's office and I'll say everything's fine, and I might have an issue going on that probably could have been helpful or would have been good to discuss. I think it would be best if you can just be upfront about concerns about things like memory or being forgetful, trouble with language or expressing yourself or speaking. I think are very important to talk about with your doctor as well. Also, if you can provide specific examples for your doctor or for your neuropsychologist if you go for an evaluation, that's really helpful, because that can direct us in ways to tailor your evaluation, determine whether or not there are additional tests that might be appropriate, or work with your family to try and implement new systems or ways to manage some of the difficulties you might be experiencing. It might also guide things like recommendations in the future for us and for your other medical providers as well. So examples are great. I would say about 80% of the time somebody comes in and just tells me my memory is terrible. And then I spend another 10 or 15 minutes pulling out what terrible means in terms of your memory. But if you have good examples up front, I might be able to save you a little bit of that work. And then asking for assistance if you need it, I think is an important thing to note as well. I'm a really independent person. I would imagine a lot of people out there in the room today are very independent-minded people who have been very successful in life. And sometimes when that happens and things get in the way, where things become more difficult, it can be hard to ask for assistance and help. But I think talking about assistance that you might need with memory or with your thinking skills can be very important. So trying to break down that barrier. Start with somebody who you trust, who's very close to you, usually like a spouse or a partner, before you start bringing in family members or community friends, things like that. So this is the group participation portion. I'm curious, what do you guys think neuropsychology is? If somebody said, oh, you need to go see a neuropsychologist, anybody have any ideas about what that looks like? No? No guess? So, neuropsychology is kind of a difficult thing to nail down specifically because we kind of span across multiple domains of medicine. So neuropsychologists are trained initially as psychologists, and then we specialize with additional training in neuropsychology, which is more on the neurology end of medicine. So we bridge the behavioral elements of psychology, physiological processes, the nervous system, and all of that, integrating it into kind of one understanding of an individual's thinking or cognitive abilities. So really simply, it's the relationship between behavior, emotion, cognition, and the brain. So kind of why I got interested in it was this integration of the medical and psychological and the biological. So when you go see a neuropsychologist, you should know that we're not the same as therapists or counselors or even as neurologists. We're kind of a very unique set that integrates those skills. We often work in hospitals, clinics. There are private practice neuropsychologists as well out there. There are quite a few of them in the VA system, mainly because of brain injury and chemical exposure, things like that. We are all specially trained, but we're not MDs. So I have a PhD in clinical psychology. There's another type of doctoral degree in psychology called a PsyD. Many neuropsychologists are also PsyDs, but we are not MDs or DOs. So because of that, we don't prescribe medicine. I don't order your MRIs. I'm not going to send you for more blood tests. I might recommend that your doctors look at that, but I don't do that myself. And in order to get a PhD or a PsyD and become a neuropsychologist, you spend about 9 years in college to get your degree. And then I spent an additional 2.5 years in postdoctoral work. So I've been doing this a long time. I'm coming up on 13 years now after I graduated from high school to do this. And almost all neuropsychologists complete a 2-year fellowship in neuropsychology. So what exactly do we do? I kind of touched on it a little bit, but we integrate your medical history, your psychological concerns, things like depression or anxiety, psychosocial stressors, your family background and information, personal stressors, things that are going on in your life right now, your functional abilities. So that's your ability to complete tasks, like I mentioned earlier, paying your bills or washing your own laundry, making food at home, things like that. And then your level of independence. How much assistance do you require on a day-to-day basis? How much help do you need to get those things done? We integrate kind of all of that with the goal of understanding your current functioning and how that reflects a diagnosis or a condition you might be dealing with, and then provide recommendations and assist with treatment planning to ensure that you're getting optimal benefit from the medical interventions and treatment you're given. Okay. So any questions about any of that so far? Or I kind of get into it a little bit more? No? So in terms of Parkinson's disease, one of the questions that I got emailed was, what's the role of neuropsychology in Parkinson's disease? The first is just to assess for cognitive change, because we know that's an element of Parkinson's disease for most individuals. So knowing that that's the case, that's a primary responsibility. I've been doing quite a few pre-surgical evaluations as well for deep brain stimulation. This is standard of care, is to have an evaluation done in advance of any DBS placement. Primarily because right now DBS is not approved for placement in individuals with dementia. So if you were diagnosed with dementia, it wouldn't be appropriate to implant you based on the FDA guidelines. So that's DBS surgery in and of itself is kind of a whole other topic that you may have heard from other people about in the past. But we play an important role in that in terms of we look at your cognitive abilities to make sure that we're not going to do additional and significant harm by implanting a deep brain device. And we participate in the multidisciplinary team meetings that discuss your case. We also provide diagnostic clarification. So as I said before, some conditions look very similar to Parkinson's disease. I don't, I'm not going to put anyone on the spot, but I would imagine when you were in the process of getting diagnosed, you might have been told it could be X, it could be Y, it could be Z. Some of the common conditions that look like Parkinson's disease are things like Lewy body disease or Lewy body dementia. There are also some other movement disorders that can look like Parkinson's disease that sometimes are misdiagnosed. So one of our roles as neuropsychologists is to provide some clarification if that's a concern. And then we also assist with treatment planning. So making sure that all of the treatments that are being implemented are supporting you and that they're appropriate for your cognitive and intellectual ability level based on our evaluation. We can also provide recommendations to providers if there are gaps in care or things that haven't necessarily been well addressed. So those are the kinds of things we assist with as well. Then, as I mentioned, pre and post surgical evaluations. So many people will come back and be reevaluated after their DBS placement just to see if there are any cognitive changes or if there are significant changes noted afterwards, then we can compare the two time points. So when do you need a neuropsychological evaluation? I would say if you feel like you're having significant changes, things are getting a lot harder for you, there are more concerns from your family or your loved ones about mistakes or errors being made, a neuropsychological evaluation makes a lot of sense. Sometimes people are also referred if a provider feels like it might be helpful to discuss alternative treatments or to look at other functional, improvements. So do you need in-home care and assistance, things like that? A neuropsychological evaluation can be helpful to kind of identify your current abilities and your current level of functioning, and the providers use that sometimes to make recommendations. If you're considering DBS, like I mentioned, or other neurosurgical procedures, then this could be useful. If there are questions about capacity or independence, that can also be a reason to be referred for a neuropsychological evaluation. Although I don't do those kinds of evaluations regularly, they are an important part of what neuropsychologists do. And then also to determine eligibility for support programs and insurance coverage, things like that. Sometimes they will require a cognitive evaluation, and neuropsychologists are often the individuals who do those reports. So how do you get a neuropsychological evaluation? It usually requires a referral from your doctor. So a primary care doctor, a neurologist, a movement disorder specialist, somebody like that could write an order, send a referral in. It can take a long time to get a neuropsych appointment. When I first started at UNMC, we were over 12 months wait list. Right now we're at about 4.5, 5, maybe, depending on how you get referred. Some other health systems around here are 9 to 12 months still. So if you feel like you want a neuropsychological evaluation or it's recommended by a provider, I tell people to kind of jump on it as soon as they can. Because the earlier we can understand the concerns or the issues somebody might be having, the sooner we could provide some intervention or assistance to make sure that they're well supported and that they're going to benefit from treatment. Most of these evaluations are covered by insurance. Medicare pretty much covers them fully without any pre-authorization. If you use a supplement or if you're using private insurance because you're not of Medicare age, then it's a little bit different, but they're almost always covered. We just kind of have to jump through, a bunch of hoops and a bunch of paperwork to get it done sometimes, but I haven't heard any real problems with that. So before you show up, let's say we got you scheduled and you're going to see me next week at UNMC for your neuropsychological evaluation. I'm going to spend a couple of hours going through your medical records. So I'm going to look through all of your lab results, I'm going to look through imaging, I'm going to look through your personal history that we have available, your recent medical visits, those kinds of things, so I can understand what might be going on for you. That allows me to get a better sense of what we might need to address or tackle in terms of the testing and the evaluation itself. We'll probably send you some questionnaires, things, yeah. Yes.
Should I say that for that, or should I just bring it with?
Yeah, so she had a question about, she has an upcoming neuropsychological appointment, and she was curious about needing to send information. Every place that you get evaluated is going to be a little bit different. If you're coming to UNMC or Nebraska Medicine, then if you are in our health system, we have a lot of your medical records likely already. If not, we ask questions during the interview to kind of get a sense of your medical history and background, and we may have to sign a release if we need it. So I don't tell people to send records necessarily in advance. I usually have pretty good access to records. Like I can get CHI's records very easily. I have a lot of national records available as well for our healthcare system. So that's a good question though. If you have information you feel would be helpful, like you went to another provider or had another evaluation in the past, always bring that in. I'm always happy to see more information. If I choose not to use it or if I already had it, then that's not really a barrier for me. But if you happen to have it, or some people are really detail oriented and have a big 3-inch binder filled with everything they've ever done in terms of their medical care, if you're one of those people, that's fine, bring that in and then we can look through it together and see if there's anything we need to copy or to add back into your medical records. We usually send questionnaires or a personal history form out to individuals. Please try and complete those if you can, bring them in, because that saves us some time during the interview and it also reduces kind of like double effort if we've already got that information. If you can, I almost always want somebody to bring a support individual with them into the interview, into the appointment. So this is usually a spouse or a family member or a caregiver, somebody who knows you well, who has seen maybe the changes in terms of your thinking or your physical symptoms so that they can provide information that maybe you aren't aware of or that are more difficult for you to recognize. And then neuropsychological appointments can be stressful. I don't think they should be, but I understand why people might be worried about them or stressed about them. Very often people tell me they've been anxious or worried for weeks about their appointment or they didn't sleep well the night before because of it. This is perfectly normal. I just recommend you be honest with your providers and upfront about those concerns. So if you didn't sleep well the night before, let us know because that might have impacted your testing. And I'd like to know that so that I'm not judging you maybe inappropriately or evaluating the performance of the test, presuming that you slept your normal 7 or 8 hours when you only got 3 or 4. So now that you've brought all your paperwork and you showed up to the appointment, what does it look like on the day of the evaluation? I want you to get a good amount of sleep the night before, like I said. Take all the prescription medication that you normally do, have a nice breakfast if that's what you do in the morning, don't skip your cup of coffee. We have coffee in the office, it's not very good, but if you want the bad coffee in my office, I'm happy to give you a cup. Bring your hearing aids or glasses. If you use a walker, bring that. Whatever you need to make yourself comfortable and make you able to see and hear adequately, that's what we really need. Allow additional time to locate the office. If you've ever been to our neuropsychology clinic at UNMC, it's kind of in a weird place, in a weird building. So I think give yourself a little bit of time to make sure you can find the location. That reduces your stress and also the stress on everybody else around you. Bring those history and insurance forms and cards and any other documentation you think might be helpful. And then have water and snacks available. This is a pretty long appointment for most people. I think the shortest evaluation might be a couple of hours, but many people it's at least a half day. So it's a good idea to just make sure that you're comfortable. If you want to bring iced coffee with you from Starbucks or something, bring that. I've had people bring in like whole coolers full of snacks and sandwiches. They were there for like 3 hours. I don't know what their normal life looks like. That's a lot of food for 3 hours, but if that's what they want to bring, they can. So what does neuropsychological assessment involve? There's basically 3 components. So we have an interview. takes between 30 and 90 minutes for most cases. This is my opportunity to get to know you as the patient and for me to understand your background and what you're experiencing. So I'll ask you questions about your personal history, what's going on currently, and then also what you want to get out of the evaluation. And then we do the testing. The testing is kind of variable in length. It's usually about 2 to 4 hours of testing. It can be longer, it can be shorter, just depending on what we need and what we're able to complete. Because we are flexible in that way, trying to understand what's possible and then also what we need to do in order to answer the questions. And then there's a follow-up appointment, usually a couple of weeks after your testing is completed, where we review the report with you. We'll go over the results, answer questions that you or your family members might have, and that usually takes about an hour. So that interview, I'm gonna be kind of nosy during the interview. I ask you a lot of personal questions. I ask you about your medical history, your family background, what your mood is like right now. I ask about substance use. I ask about any stressors currently going on at home. This is important because all of these things we know affect your thinking skills and your cognition. If you're anxious and worried and stressed at home, if you're dealing with a lot of financial distress right now, maybe you got defrauded recently and you're trying to manage those things, those can distract you during our tests. So it's important for me to understand that. It's also important for me to understand your background and your history. Just because you come to me at this point in your life with maybe Parkinson's disease or you're having some memory difficulties, doesn't mean that I can ignore the things that happened in the past that might have led to this point in your life and all the things that might contribute to changes in your thinking. So understanding your family history, a history of any abuse or trauma you might have experienced is also very important. We also ask about employment experience and educational background because these kind of give us a clue as to what sort of intellectual ability you might have had before anything started to change. So, if somebody was a physician or an attorney and now they're functioning at a very low level relative to that, that's different than somebody who might have worked in a cafeteria or worked in an unskilled labor position and also had some declines. So we have to have an understanding of what baseline we're kind of looking at. So to get at that, we have to look at a lot of your background and personal information. Now, the interview can also be really useful with a collateral for the same reasons. Our brain is very good at hiding the mistakes that we make and the things that we don't understand. So I don't know if any of you ever did this in I think I did it in a high school or a middle school science class where we learned about the blind spot in our vision. So, you hold the dot in front of your face with one eye closed and you kind of move it back and forth until the dot disappears in your vision because we all have a blind spot. Our brain is very good at filling that blind spot in with what it thinks is reasonable information. And if we start to have difficulty with our memory or our thinking skills, our brain does that as well. So it's important to have people around us who might see these difficulties or have known us for 10, 20, 30, 50 years and can speak to the changes that have happened more recently and what they've noticed. Also, the person that comes with you can provide a lot of emotional support. If I'm asking challenging questions, or if you're very worried or stressed during the evaluation, having somebody that you've known for many years that you trust and who is there for you can mean a lot. So I always want people to bring somebody with them to these evaluations.
Question.
Yeah. Oh, yeah.
Could that be more from one person?
So the question was, can that be more than one individual?
As a support?
Yeah, so I have had interviews with 6 family members. It gets a little cumbersome when it gets that large, but 2 or 3 people is perfectly manageable, especially if the person who's being evaluated is having a lot of trouble expressing themselves. So I've worked with individuals with Parkinson's disease who are very dysarthric in their speech. It can be very difficult to understand them, very effortful for them to make speech sounds. When that's the case, sometimes having a couple of people in the room is helpful because somebody might know what that means, the other person might know what that means. I think more than 2 or 3 is probably unnecessary unless there's a specific reason for it. Like if I have had cases where there have been multiple powers of attorney or people who hold different decision-making capacity for the individual I'm testing. And if that's the case, then I want them all there because they represent that person's legal rights, right? So I don't want necessarily the person who makes their financial decisions to not be there for that appointment. I would like them all to be there if I can put that up. Yeah, does that answer your question?
Yeah.
Okay. But I'm always happy to have a couple of people in the room. I think it's helpful. It's just harder on me. I just have to wrangle more people when I'm talking to them, but other than that, it's fun. All right. So any questions about the interview process or anything else that we've gone over so far? Okay. So I'm going to talk a little bit about the testing. I'm not going to talk about specific tests. And there are a couple of reasons for that. One of the reasons not to talk about specific tests is if I tell you about them, then you know about them, and you might perform differently on them than if you went into that appointment naive without any awareness of what those tests might look like. So I'm not going to discuss them specifically. The other reason is that some of you may actually have to do this in the future, and I don't necessarily want you to try to practice or learn about the tests in advance, because that doesn't help us. That just shows me that you studied, not that what your current ability levels are. So, but I'm going to talk about testing more in the abstract. So, like I said before, testing times can be variable. So you might be there for 1 to 2 hours, you might be there. I have had people test for 7 or 8 hours over 2 days before, but those were for different kinds of cases. For most Parkinson's disease related cases, it's about 3 to 4 hours of testing. That's so that we can get a good sense of every domain that we assess for in your cognitive abilities. You're going to complete a bunch of different tasks. When I was learning how to assess children, I called them games and fun puzzles. It doesn't work as much with people over the age of 12 to call them fun games and puzzles, but if you want to think about them that way, that might be helpful. The providers, like me, the doctors may do the test, but at a lot of places we use what are called psychometrists. These are specially trained technicians who will complete the tasks with you. So we do the interview, and then the psychometrist will come in and spend several hours with you testing while we work on your report and other information. Tasks are really selected based on the question that's trying to be answered and what we need to understand about your cognitive performance. So based on the interview and then also what you need the evaluation for. Some of you may have done things like a MOCA exam, which is kind of a brief one-page test that your doctor might give like at an annual Medicare wellness visit. Or you might have done like remembering 3 words, and then at the end of your doctor's appointment, they asked what those 3 words were. We do things that are similar, but much more in-depth, much more comprehensive, and we look at far more variables than those evaluations do, those measures. Okay. So the tests cover a lot of domains. So we're looking at things like language, memory, visual-spatial abilities, executive functioning, motor skills, all of those things and more. Most of them require speaking, reading, writing, and or drawing, but we do have ways that we can modify or adapt the assessment depending on your ability. So especially with individuals with Parkinson's disease, writing can be very difficult, speaking quickly can also be very difficult. So we understand that, and we have some adaptations and things that we can do to manage those difficulties. Testing can be tiring, and it can also be frustrating for people. That's kind of just par for the course when it comes to intellectual and cognitive testing. So I warn people up front when they start that they're probably going to get mad at me, they're probably going to be annoyed with me at points in time. That's totally okay. I don't take it personally. By the end, hopefully you still like me, and then you'll come back for your follow-up appointment. Tests are designed to be difficult. If the tests were easy, we wouldn't know where your top level of ability and skill are. So if you're completing a task and somebody were to stop it before it looks like you're done, or there's more spaces on the page, that doesn't mean that you did poorly. What it means is that you completed what we expected you to, or we have to stop because of some sort of time limitation on the task. When we look at your performances overall, we're not looking at how many boxes you filled in specifically, but we're comparing your performance to other individuals who are like you. So this is that normative peers that we compare you to. So we look, let's say you're a 65-year-old woman with a high school diploma. We're going to look at other 65-year-old women with high school diplomas to compare you. To the best of our ability, we try to compare apples to apples in that way. So we talk about that quite a bit usually during the feedback appointment. Sometimes I get pushback saying, that was a lot harder than I thought. I didn't think I did really well, but you said it's fine. it's probably because when you were in high school or when you were working full-time, you might have been able to do better on that task, but you're forgetting that 20 years has elapsed since you last went into an office and worked, right? So things change in that time frame. So we say goodbye, I send you on your way, and then my work starts. So I write a report. Usually the report is between 12 and 20 pages long. It integrates all of your medical history, your personal history, the concerns that you currently have going on. And then I forward that to the doctor who referred you to us once it's complete. It also goes into your medical record. So it's available there for other physicians in the health system that you're seeing if they need to go in and look at it. I then schedule a feedback appointment with you, usually the same day as the evaluation, to go over the results. And that's usually going to be done with the neuropsychologist and take about an hour or so to go over all the results. And then I document everything else. So, I file your insurance billing and all that kind of stuff. But most of this is behind the scenes. You don't see most of it. So what goes in that really long report? As I said, it's kind of a summary of your personal and medical history. It's got a table of scores for all the tests that you completed, showing how you did compared to that normative peer group that I mentioned earlier. It's got current concerns and the abilities that we think you might have functionally based on our conversation and what you reported, and then a summary of overall performance on all of these tasks. Then we review the possible causes or etiologies of any changes that you might have. So if we find you're having difficulty in memory and you're slightly slow or having some processing speed difficulties, we integrate that together and try to figure out what that might mean in the context of your personal and medical history. Okay. And then if it's appropriate, we make a diagnosis and potentially make prognostic kind of statements about whether or not this is likely to change over time, whether or not it's likely to be stable. So when we think about the course of disease in neuropsychology, we think about whether or not something is degenerative, that means likely to continue getting worse, or is it something that was the result of a single incident or a single act that happened? So if somebody has a stroke one time, they may have cognitive changes, but unless they have additional strokes in the future, we usually view that as being fairly stable. It's less likely that they would have additional cognitive changes over time from that stroke. Unfortunately, conditions like Alzheimer's disease, Parkinson's disease are degenerative. They continue to worsen over time, even with medication and appropriate management for most individuals. So we would say those are degenerative. So potentially there could be additional changes in the future from the time that we evaluate somebody. So that's just what we do in terms of that. One other thing about the diagnosis. So I'm talking to a Parkinson's disease group. It would be likely that Parkinson's disease would be in that diagnosis list. But if you also had other conditions that were contributing to difficulties, things like, let's say, unmanaged depression or sleep apnea that wasn't treated, things like that, that might also go in your diagnosis list because they could be affecting your thinking skills. So we don't necessarily just stop at the point where another doctor gave a diagnosis. We may identify other things that could be addressed or treated that might improve cognitive abilities, or at least preserve the cognitive abilities that are there. So the feedback appointment, I think, is the most important part of the evaluation for most individuals. You're not going to get a whole lot out of us during the interview or during the assessment, the testing part of the evaluation, because we can't really tell you, oh, you did great on that, you did poorly on that, because we have to go through and score it. We also don't want to influence your performance on those tests. So this feedback appointment is our opportunity to share our thoughts directly with you and for you to ask questions of us so that you can better understand what we have in that report. So again, we want people to come. I've had people with children out of state who call in on their phone and we just put them on speakerphone, leave the phone on the table while I talk through the results. I'm perfectly happy to do that. We often offer telehealth visits because we know that mobility can be difficult for some patients, transportation can be difficult. A lot of providers offer that as well. So we want to make sure that it's accessible for everybody and that anybody who feels like they should participate in this can. It's usually about an hour, sometimes they're 90 minutes long. And the discussion is really me going over the results with you, showing you where we found some difficulties, what we think is going on, and then the recommendations that we provide. So the recommendations that are often in our reports are kind of in several different categories. So we have medical recommendations. These are things related to potential additional evaluation, treatment, maybe referral to another specialist you haven't been working with, like I mentioned, sleep. So sleep is very important for thinking skills, and if you've noticed cognitive changes and you have maybe snoring or quality of sleep, meeting with a sleep medicine specialist could be helpful. So those kinds of things we might recommend. Mental health as well. So depression and anxiety are very big drivers of cognitive difficulty in individuals. So if we notice any of those concerns, we might recommend you talk to a counselor or work with a psychiatrist to see if medication could help. Lifestyle changes. We want everybody to be physically active, reduce their substance use, and be social. So those sorts of things can be very important in terms of maintaining quality of life. And then functional concerns, like do you need assistance with the basics of everyday living? Things like dressing, bathing, eating. Do you need help with more complex instrumental activities? Things like paying the bills, driving, navigating around stores, things like that. And then reevaluation is something that is kind of unpredictable. Sometimes we need to reevaluate you, sometimes not. Usually if it's a new diagnosis of something that might get worse, we will recommend that you'll come back for a reevaluation, but not always. And very often we allow other providers to kind of monitor with those briefer measures just to see if things change over time, then they can refer you back. This isn't like a colonoscopy. You don't have to come see me every 5 or 10 years. So when the doctors feel like it's appropriate, they can just place that referral again. So after the assessment, like what happens after that? Who gets the results? We send it to the referring doctor. And then if you tell me that you want me to send it to your primary care or anything like that, I'm happy to forward them. I just need your approval for that. I also give people a copy for their own records. I will usually print out and mail a copy to individuals. If you don't agree with the results, what if you're confused by them? You feel like Dr. Grinman got it all wrong. You wouldn't be the first person who thought Dr. Grinman got it all wrong, so that's okay. I suggest you talk about it with your provider. So whoever did the evaluation, if you don't feel like it reflects you, then make sure they know. It may not change the interpretation, because like I said, we try to be as objective as we can in terms of interpreting your performance, but it doesn't mean that we don't want to hear about your experience or what you think is going on. And if we made an error, we do correct it. We're not above like acknowledging if there was something that was out of whack or if something in your history was wrong, you can let us know. What will the results impact my ability to do X? So driving is a big thing. We live in a place where it's very hard to get anywhere without being able to drive. And I am very sensitive to this, but my goal is to make sure that you are safe and that everybody around you is safe as well. We are not mandated reporters to the DMV in Nebraska. So psychologists are not mandated to report. However, if we put concerns into our evaluation about driving ability or navigation ability, another doctor, like your primary care doctor or your neurologist, may see that and may talk to you about restricting driving or making a report. So it's just something to be aware of. Ability to drive and driving safety in individuals with Parkinson's disease or with cognitive change is probably a whole talk in and of itself. So if you guys feel like you want that in the future, let them know, and I'm happy to come back and talk about that all on my own. And will my medications change? I don't change medications because I'm not a medical doctor. So your medical doctor may change medications based on what we recommend. Sometimes people are on a large number of medications that can cause changes in thinking or make it harder to think through things. And if that's the case, doctors may want to change some of that. And then, are memory medications safe in PD patients? This is a good question for your neurologist. I will say that there have been studies that show that they aren't unsafe, but whether or not you get the same benefits that somebody like with Alzheimer's disease might have is a better question for your neurologist based on their understanding of the latest research. So I just kind of try to step away from the medication question for most of those incidents because it's not really my area of expertise. So. The other big area that I get a lot of questions about is legal, financial, like assisted living kind of questions. There are two types of evaluations that are largely done for this. There's the cognitive evaluation, which is what I talked about, and then there's a capacity evaluation. A capacity evaluation is the way that in the legal system, they determine whether or not you're able to make your own decisions, able to manage your own affairs. That's what a capacity evaluation is. I think that there is a fair amount of overlap between what we would do in a cognitive and a capacity evaluation. But it's important to be upfront with your neuropsychological provider if you are planning to use an evaluation for a legal purpose, just so that we're aware upfront. It may not change what we do or how we administer it, but it might change like the questions we ask or something that, how we might report something in the end, just to clarify things. It can be a concern, but sometimes you actually need a whole separate evaluation to determine whether or not you have capacity to make medical and legal decisions, because it's a different sort of evaluation process. For any legal concerns, I always recommend people talk to an attorney, especially around things like power of attorney, estate planning, living wills, things like that. It's much better to talk to somebody who's very familiar with that rather than rely on what you find online. If that's difficult or not financially feasible for you, you could try talking to social workers or other individuals who work with older adults. There's the Eastern Nebraska Office on Aging that has people who provide assistance with these sorts of things as well. And then I always want people to consult with a trusted family member or a friend when they're making major decisions, especially if they know they've had some changes in their thinking. So if we tell you that you have some minor changes in cognition, that's maybe just a key or a sign for you to start relying on some other people to help bounce ideas off of. Maybe you want to buy a new car, but it might be a good idea to talk about that with your friend or with your child or with your spouse before you do that decision. Thinking about whether or not it's practical or necessary, especially given maybe concerns about driving, or whether or not it's time to bring in-home care or assistance, things like that. Those are important things to discuss with others. And that's all. That was quite a lot, and I didn't stop talking for a while. If anybody else has any questions, please feel free to raise your hand. I think we might have a microphone to pass around if anybody has any questions.
I have one. I don't know if this is where, oh, there we go. For those people who are awaiting a DBS evaluation, is it still a 10, 12-month wait to get on it? Because that would really delay the process, I would think.
Yeah, we are not usually the reason that DBS gets delayed, is what I will say. If you have a provider who's recommending DBS or suggested that you look into it and you're going through the workup, it's usually a shorter time frame. But we often see people with Parkinson's disease for evaluations outside of a DBS evaluation as well. So it shouldn't be a barrier to doing DBS. Yeah.
That's good. Anyone else? I think you should show us a couple of those puzzles games. Just
I
joking.
can't, sorry. I thought about bringing the kid ones, the ones for like pediatrics, because you guys are a little past that age, so I can show you those, but.
One has the question. Let's see.
Why does it take some sort of evaluation to qualify for DBS?
So the qualification for DBS from a neuropsychological standpoint is we need to make sure that you have adequate intellectual ability to understand the process of the surgery, the possible consequences and side effects of the surgery. So we need to make sure that you're aware of that. We also then need to make sure that you don't currently meet criteria for dementia, because that is not allowable under the current FDA guidelines for DBS placement. Other than that, there aren't a lot of other neuropsychological guidelines around that. A lot of surgeons will not implant somebody who has active substance use disorder. So if somebody is actively an alcoholic or using other substances and not receiving treatment, or if they have other complications, then a surgeon may find that as a contraindication. We also want people to have good support, or at least a support system in place following surgery, because there is a recovery period, you need transportation to and from programming appointments, things like that. So we look at all of those kinds of pieces in our neuropsychological evaluation, but we are just one cog in a very complex kind of system when it comes to DBS. Yeah, the other elements of DBS qualification are probably better addressed by like the neurosurgeon and the neurologist. They would know better than I would.
You notice our neighbor has a shaking of his right hand. What? I was wondering if he's looking for a. See what we have, pardon.
So you were saying shaking in the right hand, sorry, I'm not sure I understood the question.
Should he be looking to see if he can get farther?
Ah, okay. So he was just saying if somebody has some shakiness or trembling, like in their right hand, should they be evaluated for Parkinson's? Look at it that way. I think it's very good to talk to your doctor about any changes in physical symptoms like that, because Parkinson's isn't the only condition that causes shakiness, right? So essential tremor is more common than Parkinson's disease, and that's a benign condition that causes trembling and shaking in the hands. That's also treated by DBS and actually some of the same medications as Parkinson's disease too. So, yeah, did that answer your question, sir? Okay.
Other questions? Okay,
Well, I'll stay around for a few minutes if anybody wants to ask any questions one-on-one. But it's been very nice talking to you, and I'm glad that there's such a large support group for Parkinson's disease. So I'll definitely let people know. It's a little far from Omaha, where most of my patients are, but I think it's definitely worth it.
we appreciate you coming to the. And if you have people from Lincoln that don't know about our support group, we've got some brochures we can send with you, right, Sally? We are very happy that Dr. Freeman was willing to come to join us today and fill us with knowledge about the neuropsych tests. We've had over the years, people have questioned us, and we wanted to get some expertise. Again, thank you. Now we will go over a few things for our business meeting. Do we have new people? People who've never been? I see them right here.
Steve Stover, this is Warwick Jam.
Well, we're happy to have you. We hope you'll come back. I see fingers pointing. Oh, I see hands raising.
I'm Jack Schultz, and this is my wife, Kathy.
Finger pointing. Oh.
My name is Jolene Lee.
See another hand.
I'm Brian Newman, and this is my wife, Missy.
Glad you came.
Steve Miller and my wife, Chris.
Hello, yeah.
Steve Miller and my wife, Chris.
Others who have not been here before? Okay, well, we're glad to have you, and we hope you'll come back, and we assume you left your email address so that you can get all the information about our meetings and things that are coming up. We try to keep everyone informed. Just a reminder that UNMC has a symposium every fall. And if you haven't known about it, you should. They're very good. It's a very good opportunity to learn things from the pros. And this year it is going to be on October 1st, which is a Wednesday. And it's they have it at the Embassy Suites in La Vista. Now, they haven't sent out the registration forms yet, but they will be probably pretty soon, and when that comes, we'll send a reminder to all those who are on our email list. Well, you see some paper on your table? If you have a topic that you would like us to consider for next year, please write it on the white piece of paper, and then you can leave it there, and we'll get it at the end of the meeting. We love suggestions for topics. Now, Sally. Sally has a couple of things. I'll talk about this while she gets her thing. Over here on the table now, Jim, raise your hand, Jim. He is our librarian, so to speak. He brings things from home that people seem to enjoy. So after the meeting, look at the table and see if there's any material that you'd like, because you can take it. On the table is a little card, and it says Lincoln Parkinson's Disease Support Group. And it has some information on it so that if people have this, they can give us a call, email us, and we can help them out with as much as we can, and certainly invite them to come to this meeting. Sally.
So send over
Over here.
to get away from the window.
Do I have to? Okay, I guess I want to just bring up, we've got our brochures for the Lincoln Support Group here with information on books, resources. Now, Michael J. Fox, Parkinson's, Nebraska, Davis Finney. And the meeting times and things. You're welcome to take these. We're trying to get them distributed out to any of the doctor's offices. So if anybody wants to grab some extra ones, if they're going to a doctor or driving by a doctor's office, just come and I'll give you some of these and we can get them distributed so more people know about our group.
I took the stack that she had, and in May I had a knee replacement, and so I went to the therapy. They took some, I took it to the surgeon's office, they took some. What else? I've been taken wherever I'm talking to anybody medical. I think I've checked it about 5 places, and every one of them has been very courteous. And I won't say anxious, but but they found a place right away, and they were happy to put those out for us. I don't know if I have to go back and see if any of them are gone, but anyway, I think it doesn't just have to be an MD, is what I'm getting at.
Right. And Jim and I realized we need to carry these in our car because I don't know how many different doctors or different places, medical places we've been. And we get there and go, oh, we should have brought some pamphlets with us.
So we should all get some and put them in our car. And when we arrive, wherever it is, get them out and share them. Let me see. Thank you, Gunter, for doing the Zoom for us. And thank you, Zoom people, for joining us. And thank you all for joining us next month. Dr. Erin Smith, some of you might go to her. She's going to talk about research, and she does Botox, so we'll hope that she'll throw a little Botox info in there. That'll be August 24th. So mark that on your calendar. And of course, again, we're thankful for Gunter and Sally and Jim for providing information, and Sally for also providing, I guess that was a couple of things, Sally, providing refreshments. So what we do at this point, for those of you who have not joined us, we divide into 2 groups. Those who are caregivers will meet in the kitchen, and those who are not caregivers will stay in this room and we will be able to talk about things that interest us or questions that we have. And then about 4, we'll mosey home. So again, thank you for coming. Anything else? Does anyone else have an announcement or information for the group? Okay, well, we'll divide up and have a feast.